Hi everyone, Dave Bosch here. I'm coming to you with an update on the fascia iliaca block and hip fracture pathway. Recently there's been some new literature with an update and an improved way of doing fascia iliaca blocks or hip blocks, and so I wanted to bring this to you. The technique is called a pericapsular nerve group block or a PENG block. And I will show you during this video how it works and how it is beneficial and probably superior to the fascia iliaca block. Well, you may say, well, why would we improve something that's so new? Fascia iliaca blocks, we've only been doing them for a couple years. Is it really time to start doing something different and new? I would argue that the fascia iliaca block is great, but I feel that it is very limited in what it can offer, and essentially in that it's a difficult block to do in older people, which is essentially our hip block population. The reason being is that the fascia iliaca is a difficult structure to see in somebody who has 90 years plus behind them. And so that can lead to a lot of misses. I find that my blocks are oftentimes either spot on or a complete utter failure. And the fascia iliaca block has been described to cause some distal muscle weakness, which is not great for postoperative hip fracture patients. I think it's time that we innovate. We always want to keep you guys on the forefront of the ultrasound literature, what's new, and this is one example of how I think we can improve the fascia iliaca block. If we compare them directly, the fascia iliaca block and the PENG block do very similar anesthesia to the hip. They both get the femoral obturator nerves. The PENG block gets the accessory obturator nerve, whereas the fascia iliaca block gets the lateral femoral cutaneous nerve. They both are great for femoral neck and intertrochanteric fractures, but the PENG block will also anesthetize the pelvis, giving you the acetabular fracture, pelvic rami fracture, and hip dislocation anesthesia that the fascia iliaca block does not give you. Like I said before, the fascia block does do more proximal anesthesia, which can cause some muscle weakness, whereas the PENG block does more terminal nerve sensory fiber block, which is beneficial in that it just causes sensory anesthesia, not motor. I think the fascia iliaca block is harder to perform than the PENG block, and although the fascia iliaca block has been more rigorously studied in the emergency literature. So this is an example of the drawing of the pelvis, whereas the femoral nerve and the lumbar plexus comes down through the top and mid portion of the pelvis. This is just obviously a representation of what we're trying to shoot for. The area or the spot we're going to try to shoot for is the exact same as the fascia iliaca block. So essentially you're in line with the inguinal canal, in plane with your ultrasound. And this is what we're talking about. So the area here right along the pelvis is the area where all these small distal fibers are. And if we can get some anesthesia right onto the pelvic wall there, we can essentially anesthetize all these distal fibers without needing to block any major nerves. So this is a shot from Highlands ultrasound. This is the anatomy in somebody, kind of showing in the middle picture between A and B is kind of where you want to line your probe up in plane, looking down towards the femoral artery. You're kind of right on top of the acetabulum there, and when you see it on ultrasound, you can see the acetabulum. You can also see the more superior pelvis, and this is where we want to be shooting, or at least aligning our probe. On the ultrasound, this ultrasound is using a curvilinear probe because the depth sometimes needs to be a little deeper. But I've found that the traditional linear probe works quite well for this. You just have to adjust your depth so you get down deep enough. But in this picture, you can see the femoral artery is over here medially. The lateral side is over here. And then the fascia iliaca is this ill-defined area right up here. This is the femoral head, and this is the pelvic brim here. In the second picture, they've slid the probe just superiorly, and you no longer can see the femoral head, but what you can see is the AIIS, and then the psoas tendon labeled here PT. The needle trajectory would ideally come right down and then backstop against the pelvic wall here, right beneath the psoas tendon without puncturing through the psoas tendon itself. The nice thing about this block is you don't have to relearn anything really. If you've been doing the fascia block, this is just a slight derivation of that, and I think a safer and easier approach. The supplies are the same, so just as a review, you're going to use a 20 or 30 milliliter solution of ropivacaine, 0.5%. The 0.5% bupivacaine can also be used. It's just more cardiotoxic, and so I prefer ropivacaine. To review the doses, it's 3 mg per kg max of ropivacaine and 2 mg per kg max bupivacaine. And as a reminder there, the quick math is on a 50 kilo person. Anyone higher than 50 kilos, you can use a full 30 ml vial of the ropivacaine or 20 milliliters of bupivacaine. The rest of the supplies are the same, either a 20 gauge spinal needle or the Sonoplex needle. I recommend the Sonoplex needle because it's just a lot more echogenic. Chlorhexidine, a Tegaderm, or a probe cover for the probe itself, a 30 milliliter syringe or higher, and then a fill needle. So this is an example of my inguinal canal crease, showing what we're talking about. So this is my right side. The femoral artery is listed here medially. The lateral side is off towards my ASIS. The fascia iliaca is this band of tissue here, and then this bright echogenic structure down here is the psoas tendon. It's often very easily visualized, and a lot of times people ask if that's the femoral nerve, but it's not. It lies right against the bone here, or the pelvic brim here, and it's very easily seen even in older people, which is nice. The line here that I've drawn is the ideal needle trajectory that I would use. And you can see on the ultrasound here that we're about 4 centimeters deep, maybe 3.5 centimeters deep here. And so depending on your patient, you may need to switch over to the curvilinear probe and then really reduce the depth. But if you need to get more than about 5 or 6 centimeters deep, which is the limit of most of the linear probes. This is the same picture, just no labels, just to show you the anatomy again. This iliacus muscle, psoas muscle here, then psoas tendon. There's the psoas tendon, and a video showing how I would normally find the femoral artery, and then I would slide laterally, showing the psoas tendon, and then the pelvic brim here, and then right on the top here off to the side is the anterior inferior iliac spine, the AIIS. That's your landmark. And so the next slide here is showing kind of the trajectory way off laterally where I take my needle. It's fairly steep, but you'd want to come down here and then hit bone right in front or right lateral to this psoas tendon. And the nice thing about this block is you've got a backstop. You essentially take your needle and you drive it down right until it hits the bone. And once you've hit that bone, just twist your needle a little bit to kind of puncture through that fascial plane and then start injecting. Obviously, you'd want to do an aspiration, make sure not a large vessel, but injecting right on this area will slide anesthetic kind of right underneath that psoas tendon and give the anesthesia that you need. You don't need to move it anywhere else. It's one shot, one time. So that's it. These are the references that I used. A lot of this came from the ASEP ultrasound section. They wrote a paper on this. They did that earlier this year. Highlands Ultrasound has a great website to review a lot of the details here, and I will attach the paper from ASEP on this so you can review it if you'd like. I do think that if you've been comfortable doing the fascia block, you can probably jump right into doing this after watching this video or looking through the website and kind of informing yourself more. However, if you'd like to come and do some in-person training, just reach out to me. We will have the ultrasound session for training on March 1st, so look for reminders for that. And if you'd like to come re-up on some of your skills there, we'd love to see you. Reach out if you have any questions, and take care. Have a great Christmas and New Year season.